And so I introduce Dr. Chen.
I am Pei-Ling. Thank you for giving me the opportunity to give this presentation today. I feel really honored to be here. I have no disclosure.
Can you get closer to the mic, please?
Yes, right. This is the outline and objective of my presentation today, beginning with melanoma epidemiology and impact of melanoma on the society, what happens when your physician suspects you have a melanocytic lesion, and understanding your pathology report, which is tightly linked to melanoma staging. So melanoma is a significant health and epidemiologic problem. It represents less than 1% of skin cancer cases, but the majority of skin cancer deaths. One person dies of melanoma every 52 minutes. Most melanomas are associated with exposure to UV radiation, but the less common types, such as acromelanoma, mucosal melanoma, and ocular melanomas, the role of UV is less clear. The risk factors for melanoma include family or personal history of melanoma, dysplastic nevi syndrome, UV exposure, number of moles, fair skin type, age, male gender, and immunosuppression. As we can see here, the incidence of melanoma is rising in the last 15 years. We see a greater than 600% increase in melanoma since between 1950 and 2000, as well as under 65% increase in mortality. In the 2018 American Cancer Society incidence predictions, we see about approximately 180,000 new cases of melanoma in the US predicted for 2018, of which 90,000 is invasive melanoma, and about 8,000 cases are predicted for the state of Florida, which is the second highest in the US. And within the prediction, there's also approximately 9,000 deaths predicted for 2018. Compared to 2017, there are more new cases of melanoma, but fewer deaths predicted because of the new emerging therapies. As patients with melanoma are often young or otherwise healthy, the cost of melanoma in terms of life year loss per fatality is significant. It's approximately 18.6 years, and as you can see here, it is the third highest of the common cancer types. This number has been decreased to 17.1 from the 2018 prediction. Melanoma remains a significant cause of mortality, but early detection is the key to cure. As we can see here, for early stage melanoma, the 5-year survival can reach 99%. However, for a stage 4 melanoma, the 5-year survival is significantly lower. The good news is that approximately 83% of melanoma is diagnosed at localized early stage. So early diagnosis requires routine skin checks and physical exam. So here are the ABCDEs of melanoma to demonstrate the suspicious lesions. So the features of suspicious lesions including asymmetry, irregular borders, variegated color, like difference in variety of colors, diameter, which is larger size, greater than 0.6 millimeter, as well as evolving lesions that change in size, shape, or are growing. So what happens when your physician suspects you have a melanocytic lesion? So your physician will do a biopsy of the lesion for histopathologic evaluation. The common biopsy techniques we use are shave biopsy, which requires using a blade to shave off the lesion, just like this. Punch biopsy, which uses a cookie cutter type of device to punch out the lesion, as well as excisional biopsies. I use a scalpel to cut it off. Then these biopsy specimens go to get put in formalin fill bottles. They get transferred delivered to pathology laboratories, and you go through approximately a 3-day process of processing, from cutting in the specimen, putting in cassettes, putting through formalin fixation and tissue processing, embedding into paraffin tissue blocks, cutting the tissue blocks into individual slices, putting the slices onto a slide, and then a pathologist evaluate the slide for a pathologic diagnosis. And this is our work product, the pathology report. Critical information in this report include patient information, name, MRN, and correct number, age, sex, location, clinical history, is there any recent change in size, shape, appearance, history of previous biopsies, and most importantly, a histopathologic diagnosis, as well as prognostic and staging information to guide surgeon and oncologist in treatment. Two main types of reports for your interest today are the biopsy report, as well as the surgical report covering skin re-excision plus minus sentinel lymph node biopsy. So this is an example for the biopsy report. The most important question is this melanoma or not? And if this is indeed, if there's diagnosis of melanoma, the pathologist will try to provide all the preliminary staging and prognostic information available in the biopsy specimen on hand, including parameters such as breast lobe thickness, how thick is your melanoma, does it go to the tissue edges of the small specimen, as well as other information such as tumor subtype, Clark level, is it tumor ulcerated, is there evidence of regression, is there blood vessel invasion, is this mitotically active, which is very proliferative, as well as other parameters. And we'll give a preliminary pathologic staging based on the tumor thickness from the biopsy. So what happens if your skin biopsy has a diagnosis of melanoma? Then the next goal is to completely remove this tumor, that is, leave no tumor behind and achieve a clear margin from, so this is the biopsy, and then you want to do a wider excision so that to clear this tumor from your skin, as well as staging to get the next step in treatment. So melanoma staging is critical because it determines prognosis, treatment, and decision to enroll in clinical trials. So for patients who have undergone a complete resection of melanoma, the decision of adjuvant therapy depends upon the stage and diagnosis, with a consideration, of course, for patient age, comorbidity, and personal preferences. So we use the AJCC system for the staging and classification of melanoma, and the 8th edition of AJCC was just implemented in January of this year. For melanoma staging, it incorporates the most important prognosticators of tumor, including T for primary tumor, the characteristics of the primary tumor from biopsy and re-excision, and for regional metastasis of lymph node, is there any lymph node involvement, as well as M for distant metastasis. So pathologic staging includes microstaging of the primary tumor, as well as pathologic information about the regional lymph nodes and distant metastasis. The extent and characteristics of the primary tumor and regional lymph node involvement allow the classification of patients into different risk categories. So let's begin with the T stage, which is primarily based on tumor thickness. Here we're looking at what we made into a slide, the skin tissue on slide. We measured the tumor thickness from the top of the skin layer, which is the granular layer, to where the tumor invades. And this is a schematic. We can see that the T stage is stratified essentially by tumor thickness, such that less than or equal to 1.0 millimeter is T1, 1.0 to 2.0 millimeter is T2, greater than 2.0 to 4 is T3, and greater than 4.0 is T4. This T stage is a powerful predictor of 10-year survival. You can see here T1 is 92% to T4 is significantly decreased. Importantly, this T stage also provides important therapeutic decision, such that T1B or above usually implies a sentinel lymph node biopsy. Now we go to the second component of TNM staging, which is the end stage, that is whether your regional lymph node is involved by melanoma or not. Here we're looking at a histologic section of a lymph node specimen. You can see the lymphoid tissue with involvement by a melanoma. These are the melanoma tumor cells that are pigmented. So end stage goes from 0 to 3 based on the number of clinically occult or clinically detected lymph nodes and whether there is intralymphatic regional metastasis. And it goes from N0 to N3. 1, 2 to 3 involved, greater than 4. Finally, the M stage classification, which is for distant metastasis. As we can see here, M stage goes from M0, no metastasis, to M1D based on the location of the metastasis. On your pathology report, PM1 is reported only when metastasis is documented by histopathologic examination. Otherwise, we will leave it as PMX, which is, we do not know if this is a clinically based information.
Can you talk a little bit on slowly?
Oh, yes, sorry. So all the information I have mentioned so far will go into a final surgical pathology report for re-excision. So I just showed you an example of a biopsy report of a tumor that is 1.2 millimeter in thickness in the previous biopsy. And after that, your surgeon will decide to do a complete excision, which is go for a complete removal and make the margin clear. So then you will get a surgical report from a re-excision. And depending on how thick your melanoma is, you may, so if it's greater than T1B, you will also get a sentinel lymph node biopsy. So this is, I'm showing you a couple of scenarios of what you would see in the surgical report. Here we're surgical specimen scenario 1 from this biopsy. The re-excision specimen, good news, there's no residual melanoma. So we see healing surgical wound, residual melanoma is not identified. You also have a sentinel lymph node biopsy, which is one lymph node, there is no melanoma. In this case, you will get a final pathologic staging based on the combined biopsy and re-excision specimen information. So here the combined staging is PT2A melanoma was 1.2 millimeter, no ulceration, and regional lymph node is free, so it's PN0. This is scenario 2, the same 1.2 millimeter melanoma and biopsy. When you re-excise, what we found histopathologically was that the tumor was actually thicker than your primary biopsy. Now the thickness is 4.5 millimeter in the complete re-excision specimen. Again, we want to achieve, the goal of re-excision is to achieve a free margin, a wide, clear margin so there's no tumor left behind. Again, for a tumor thickness 1.2 millimeter, you will get a sentinel lymph node biopsy. And in this example, again, the melanoma is not identified, lymph node is clear. So for this scenario, the final pathologic staging combining the information from the biopsy report and the re-excision report, your PT stage is up to PT4A because in the re-excision we found a thicker melanoma of 4.0 millimeter. But the end stage is still 0 because there's no lymph node involvement. So your physician will then translate these histopathologic information from the TNM staging into a final pathologic staging for melanoma, such that essentially stage 1 and 2 is for localized tumor. Stage 3 is tumor with regional metastasis, which is we have melanoma in the lymph nodes. And stage 4 is those with distant metastasis. So this is the take-home message today. I hope you can see that accurate diagnosis is the first step to the treatment and cure of melanoma, and that pathologists work closely with our clinical colleagues to provide essential diagnostic and staging information for melanoma, and this information is relayed in your pathology report.